Traps number 4. Pharmacology and toxicology, where two drugs share a suffix and differ in the one effect that matters, and where two poisonings look identical until one laboratory value separates them. 50 questions, each built on that separation. Which statement about these kinetics is correct? A drug is eliminated such that a CO constant amount is removed per unit time regardless of plasma concentration. A second drug is eliminated such that a constant FR CTO is removed per unit time. Read the command. Which kinetic statement is correct? Zero order and first order elimination behave differently at high doses, and that difference is where toxicity lives. First, order kinetics removes a constant fraction per unit time, so elimination is proportional to concentration and the half-life is constant. Most drugs behave this way. 0. Order kinetics removes a constant amounts per unit time because the eliminating enzyme is saturated, so there is no constant half-life. A small dose increase produces a disproportionately large rise in concentration and unpredictable accumulation. The three classic zero-order drugs are phenytoin, ethanol, and aspirin at high dose, remembered as PEA. Choice E assigns saturation to the wrong drug. The correct answer is D. The clinical consequences why this is examined rather than merely defined. A phenytoin dose increase that would be trivial in first-order kinetics can push a patient from therapeutic to toxic, producing nystagmus, ataxia, and confusion. Two related constants are worth attaching. Steady state is reached after 4 to 5 half-lives, regardless of dose, and a loading dose depends on volume of distribution, while a maintenance dose depends on clearance. If you see a drug accumulating disproportionately, leads to think zero-order saturation. Which comparison is correct? Drug X reaches half of its maximal effect at 2 mg and achieves a maximal response of 100 units. Drug Y reaches half of its maximal effect at 20 mg and also achieves 100 units. Read the command. Which comparison is correct? Potency and efficacy are independent properties, and conflating them is one of the most common pharmacology errors. Potency is the amount of drug required to produce a given effect, measured by the EC50 or ED50. A lower value means more potent. Efficacy is the maximal effect achievable, the Emax, regardless of dose. Drug X reaches half maximal effect at 1/10 the dose, so it is 10 times more potent. Both reach 100 units, so their efficacy is equal. These properties vary independently. A drug can be highly potent with low efficacy, which is why choices A, B, and E all import a difference that the data do not show. The correct answer is C. Which property matters clinically is worth stating plainly, because it is counterintuitive. Efficacy is nearly always the more important attribute, since it determines how much benefit is achievable at all, whereas potency merely determines the milligram size of the tablet. A more potent drug is not a better drug. The classic illustration is that a loop diuretic has far greater efficacy than a thiazide in producing natriuresis, independent of how many milligrams each requires. If you see two dose-response curves leads to read the horizontal shift for potency and the ceiling for efficacy. Which statement explains this change? A patient stabilized on warfarin is started on a new drug. 2 weeks later, the international normalized ratio has risen to 6.8 with no bleeding. The new drug is a potent inhibitor of hepatic cytochrome P450 enzymes. Read the command. What explains the rise in INR? Cytochrome interactions run in two directions, and warfarin is the drug where the direction matters most. Warfarin is metabolized by hepatic cytochrome P450. An I inhibitor slows that metabolism, so warfarin accumulates. Anticoagulation deepens and the INR rises, with bleeding risk. An I inducer does the opposite. Metabolism accelerates, warfarin levels fall, the INR drops, and the patient is at risk of thrombosis, which is what choice B describes. Common inhibitors include macrolides, azyl antifungals, cimetidine, amiodarone, isoniazid, ciprofloxacin, and grapefruit juice. Common inducers include rifampin, phenytoin, carbamazepine, phenobarbital, griseofulvin, and chronic alcohol. The correct answer is E. Choice D inverts a separate and equally testable relationship. Dietary vitamin K from leafy green vegetables lowers the INR by supplying the substrate warfarin blocks, which is why patients are counseled to keep intake consistent rather than to avoid it. Note also the reversal strategy, which differs by urgency. Vitamin K for a high INR without bleeding, and prothrombin complex concentrate when bleeding demands immediate correction. If you see an INR that moved after a new drug, leads to decide whether the drug inhibits or induces. Which pairing and which clinical consequence is correct? Two sedatives act on the GABA, a receptor chloride channel. Drug 1 increases the frequency of channel opening. Drug 2 increases the duration of opening. Read the command, the pairing, and the consequence. Two drug classes share a receptor and differ in a way that determines which one kills. B. Benzodiazepines. Zepines increase the frequency of GABA, a chloride channel opening. Barbiturates increase the duration, remembered as barbiturates increase duration, and benzodiazepines increase frequency. The consequence is clinical rather than academic. Benzodiazepines require GABA to be present to work, so their effect has a CE-iling and pure overdose is rarely fatal. Barbiturates, at high concentration, can open the channel directly without GABA, so there is no sealing, and respiratory depression progresses to death, which makes choice B exactly wrong on the lethality. The correct answer is A. Choice E overlooks a reversal agent that carries its own hazard and is therefore examined. Flumazenil is a competitive benzodiazepine antagonist, but giving it to a chronically dependent patient can precipitate refractory SEI scissors by abruptly removing GABAergic tone, so it is used cautiously and rarely. Barbiturates have no antidote at all. Supportive ventilation is the treatment, which compounds their danger. If you see a GABA, a sedative leads to ask whether it needs GABA present to act. Which statement about ATP and temperature is correct? Two compounds affect the electron transport chain. Compound 1 blocks complex IV, so electron flow ceases entirely. Compound 2 carries protons across the inner membrane, so the gradient dissipates while electrons continue to flow. Read the command, the statement about ATP and temperature. Two poisons cripple oxidative phosphorylation by opposite mechanisms, and the temperature separates them. An electron transport inhibitor, cyanide and carbon monoxide at complex IV, rotenone at complex I, antimycin at complex 3, stops electron flow, so no proton gradient forms and ATP synthesis fails. An uncoupler, 2,4-dimethyl-phenol, aspirin at toxic doses, and physiologically thermogenin in brown fat, allows electrons to keep flowing but lets protons elevate back across the membrane. The energy that would have made ATP is released as heat, so ATP falls while oxygen consumption rises and body temperature climbs dangerously. Choice C mistakes continued flow for continued ATP production. The correct answer is B. The hyperthermia of uncoupling is what connects this biochemistry to the clinic, and it explains a feature of salicylate poisoning seen earlier in this series. The fever in aspirin overdose is not infection but uncoupled oxidative phosphorylation. Dinitrophenol has caused fatalities when sold illicitly as a weight loss agent for precisely the same reason. It burns substrate as heat instead of storing it as ATP. If you see hyperthermia with failing ATP leads to think uncoupler, not chain inhibitor. Which agent was reversed, and what is the risk of the antidote? A 19-year-old woman is brought in unresponsive with a respiratory rate of 6 per minute and pupils of 1 mm. She responds within 2 minutes to an intravenous antidote and becomes agitated. Read the command, which agent was reversed and the antidote's risk. The toxidrome is the diagnosis, and the response confirms it. The triad of debris conscious, nessus, respiratory depression, and pinpoint pupils is the opioid toxidrome, and respiratory depression is what kills. Naloxone is a competitive MUR receptor antagonist that reverses it within minutes. The agitation that follows is precipitated withdrawal wall, unpleasant and dangerous in terms of patient cooperation, but importantly, not life-threatening, unlike alcohol or benzodiazepine withdrawal. The second hazard is duration. Naloxone has a shorter half-life than many opioids, so sedation can recur and the patient requires observation or an infusion. The correct answer is A. The asymmetry between intoxication and withdrawal is a recurring exam theme worth generalizing. For opioids, the intoxication kills and the withdrawal is merely miserable, whereas for alcohol and benzodiazepines, the withdrawal itself can be fatal through seizures and delirium tremens. Note also that meperidine and in mixed overdoses, coinestants can leave pupils mid-sized, so a normal pupil does not exclude opioid toxicity when the respiratory rate is low. If you see pinpoint pupils with hypoventilation leads to give naloxone and expect withdrawal. Which statement about the mechanism and antidote is correct? A 30-year-old man ingests 20 g of paracetamol. He is asymptomatic at 4 hours. His plasma level plots above the treatment line on the nomogram. Read the command, the mechanism, and the antidote. Paracetamol toxicity is a story about a metabolite, not the drug itself. At therapeutic doses, paracetamol is conjugated safely with a small fraction oxidized by CYP2E1 to the reactive metabolite NACQI, which glutathione neutralizes. In overdose, the conjugation pathways saturate, more NACQI is formed, glutathione is depleted, and the unopposed metabolite binds hepatocyte proteins causing centrilobular necrosis. N-acetylcysteine works by replenishing glutathione stores, and it is most effective given yearly within 8 hours, which is exactly why treatment is guided by the nomogram in an asymptomatic patient rather than waiting for choice D's transaminase rise. The correct answer is B. The deceptive clinical course is what the question is really testing. Patients are typically well for the first 24 hours, develop right upper quadrant pain and rising transaminases at 24 to 72 hours, and reach fulminant hepatic failure by 72 to 96 hours. So waiting for symptoms means treating after the window of maximum benefit has closed. Chronic alcohol use raises the risk at any given dose by inducing CYP2E1 and depleting glutathione simultaneously. If you see a paracetamol level above the treatment line, leads to give acetylcysteine before symptoms appear. Which antidotes are required? A farm worker is found confused with copious salivation, lacrimation, urinary incontinence, diarrhea, vomiting, and meiosis. He is bradycardic with wheeze and muscle fasciculations. Read the command. Which antidotes? The toxidrome is cholinergic excess, and 2 drugs are needed because 2 receptor types are involved. Organophosphates inhibit acetyl-CoA storage irreversibly, so acetylcholine accumulates at both muscarinic and nicotinic excess gives a dumbbells picture. Diarrhea, urination, meiosis, bronchospasm, bradycardia, emesis, lacrimation, salivation, and sweating, and is treated with atropine, a muscarinic antagonist. Nicotinic excess gives fasciculations and weakness, which atropine does not touching. That requires praldoxine, which reactivates the enzyme before it undergoes irreversible aging. Both are needed, which is why choice C is complete, and the single agent options are not. The correct answer is C. The urgency of pralidoxine rests on a specific chemical event worth knowing. After a period, the organophosphate enzyme bond undergoes aging and becomes permanent, after which reactivation is impossible and recovery awaits synthesis of new enzyme over weeks. Choice B names the opposite drug. Physostigmine is itself a cholinesterase inhibitor and would deepen the poisoning, making it a dangerous distractor rather than merely a wrong one. If you see cholinergic excess with fasciculations leads to give atropine and pralidoxime together. Which mechanism explains the toxicity? A 68-year-old woman on lithium for bipolar disorder is started on hydrochlorothiazide for hypertension. 2 weeks later, she has coarse tremor, ataxia, confusion, and vomiting. Read the command, the mechanism of toxicity. Lithium is handled like sodium, and anything that makes the kidney conserve sodium also makes it conserve lithium. Lithium is not metabolized or protein bound. It is cleared entirely by the kidney, and it is reabsorbed in the proximal tubule alongside sodium. Any state that triggers avid proximal sodium reabsorption therefore drags lithium back with it. Volume depletion, thiazide or loop diuretics, NSAIDs, ACE inhibitors, dehydration, and a low-salt diet. The thiazide caused mild volume contraction. Proximal reabsorption increased, and the lithium level rose into the toxic range. Choices A and B invoke pathways lithium does not use. The correct answer is E. Because lithium is small and not protein bound, it is sufficiently dialyzable, which is the treatment for severe toxicity, a property shared with methanol, ethylene glycol, and salicylate. Its chronic adverse effects are examined as often as its acute toxicity, nephrogenic diabetes, insipidus from collecting duct resistance to antidiuretic hormone, hypothyroidism, and Epstein anomaly when used in pregnancy. If you see lithium toxicity after a new drug leads to look for anything that made the kidney retain sodium. What is the appropriate management? A patient receiving heparin for pulmonary embolism has a platelet count fall from 40,000 to 68,000 on day 6 and develops a new deep vein thrombosis. Read the command. The appropriate management. A falling platelet count with a new clot is a specific and counterintuitive syndrome. Heparin induced thrombocytopenia is an immune reaction. IgG antibodies form against the heparin platelet factor 4 complex, and those antibodies acetate platelets. The result is the paradox in the stem. Platelets are consumed, so the count falls, while the activation produces thrombosis rather than bleeding. It appears typically on days 5 to 10. Management is to stop all heparin, including flushes, and to start a non-heparin anticoagulant such as agatrobin or a direct oral agent because the prothrombotic state persists after heparin is withdrawn. The correct answer is D. Two prohibitions define correct management and are what choices A, B, and E each violate. Platelet transfusion is avoided because it supplies more substrate for the ongoing activation and can worsen thrombosis. Starting warfarin alone is avoided because its early depletion of proteins C and S deepens the prothrombotic state and can cause venous limb gangrene and skin necrosis. Warfarin is introduced only after an alternative anticoagulant has taken effect and the platelet count has recovered. If you see thrombocytopenia with new thrombosis on heparin leads to stop heparin and anticoagulate differently. Which pairing is correct? Two antineoplastic agents are compared. Both are vignette alkaloids that inhibit microtubule polymerization. Drug 1 causes prominent peripheral neuropathy. Drug 2 causes prominent myelosuppression. Read the command. Which pairing is correct? Two nearly identical molecules with the same mechanism and different dose-limiting toxicities. Biacristin and biacblastin both bind tubulin and prevent microtubule polymerization, arresting cells in metaphase. Their dose-limiting toxicities differ. Biacristin causes peripheral neuropathy, areflexia, paresthesia, foot drop, and constipation from autonomic involvement, with relatively little marrow effect, which is why it appears in regimens where marrow reserve is limited. Vinblastine causes myelosuppression, captured by the mnemonic Vin-B elastine blast the marrow. Choice A reverses them. The correct answer is E. Choice C names a drug that acts on the same structure in the opposite direction, and the contrast is examined. Taxanes such as paclitaxel hyperstabilize microtubules so they cannot disassemble, whereas vinca alkaloids prevent them assembling at all. Both arrest mitosis by opposite means. It is worth carrying a short list of signature chemotherapy toxicities alongside. Doxorubicin causes dilated cardiomyopathy, bleomycin pulmonary fibrosis, cisplatin nephrotoxicity and ototoxicity, and cyclophosphamide hemorrhagic cystitis. If you see two vinca alkaloids leads to neuropathy is vincristin, maro is vinblastine. Which pairing is correct? Leucovorin is given with two different antimetabolites. With drug A, it is given to reduce toxicity after high-dose therapy, With drug B, it is given to IN secretes cytotoxic effect. Read the command. Which pairing is correct? One rescue agent with opposite effects on two drugs that both target folate metabolism. Method. Redzate inhibits dihydrofolate reductase, so reduced folate is not regenerated and cells cannot make thymidine. Leucovorin is folinic acid and already reduced folate that bypasses the blocked enzyme, so it rescues normal cells from methotrexate toxicity. 5. Fluorouracil works differently. It inhibits thymidylate synthase, and that inhibition requires a reduced folate to form a stable ternary complex. Supplying leucovorin therefore strengthens the block and enhances cytotoxicity. Choice A reverses the pair. The correct answer is D. The apparent contradiction resolves once the enzymes are separated, which is the whole point of the question. Leucovorin restores what methotrexate removed, but supplies what 5-fluorouracil needs. Methotrexate elimination is renal, and its toxicity is worsened by acidic urine, which is why high-dose protocols include hydration and urinary alkylinization alongside leucovorin, and why NSAIDs, which reduce renal clearance, are avoided. If you see, leucovorin in a regimen leads to decide whether it is rescuing or reinforcing. What is the definitive treatment? A 74-year-old man on digoxin develops nausea, confusion, and yellow-tinged vision. ECG shows atrial tachycardia with block. Potassium is 5.9 milliequivalents per liter, and creatinine has risen. Digoxin level is markedly elevated. Read the command. The definitive treatment. Severe digoxin toxicity has one specific antidote, and two of the alternatives are actively harmful. Digoxin inhibits the sodium-potassium ATPase, and in severe AKT toxicity, that inhibition drives potassium out of cells, producing hyperkalemia, which itself predicts mortality. Definitive treatment is digoxin sesquic antibody fragments, which bind the drug and are excreted renally, reversing both the arrhythmia and the hyperkalemia. Digoxin has a very large volume of distribution, being extensively tissue-bound, so it is not effectively removed by dialysis, which is why choice D fails despite seeming reasonable in renal impairment. Correct answer is A. The calcium prohibition in choice B is the classic trap and deserves its reasoning. Calcium is the normal first step for hyperkalemia, but in digoxin toxicity, the intracellular calcium is already high, and additional calcium has been associated with irreversible contracture, the stone heart. Note also the two directions of the potassium relationship, which confuses people. Acute toxicity, CAUS's hyperkalemia, while chronic hypokalemia hurtispasses to toxicity by freeing binding sites on the pump. If you see severe digoxin toxicity leads to give the antibody and withhold the calcium. Which adverse effect distinguishes them? Two antihypertensives are compared. Drug 1 blocks conversion of angiotensin I to angiotensin II and also prevents bradykinin breakdown. Drug 2 blocks the angiotensin II type 1 receptor without affecting bradykinin. Read the command. Which adverse effect distinguishes them? Two classes with nearly identical benefits and one clearly different side effect. The enzyme ACE performs two jobs, and blocking it therefore produces two consequences. Reducing angiotensin II is the therapeutic effect, shared with angiotensin receptor blockers. Preventing bradykinin degradation is unique to ACE inhibitors and produces the dry COUGH in up to a fifth of patients and, more dangerously, angioedema. Receptor blockers act downstream at the receptor, leaving bradykinin metabolism intact, which is why switching resolves the cough. Everything else the two classes share, so choices A, B, D, and E each invent a difference. The correct answer is C. Knowing what is shared matters as much as knowing what differs, because it prevents a false sense of safety when switching. Both classes raise potassium by suppressing aldosterone. Both are contraindicated in pregnancy, and both can precipitate acute kidney injury when glomerular filtration depends on efferent constriction. A creatinine rise of up to about 30% after starting either drug is expected and acceptable, reflecting reduced intraglomerular pressure rather than injury. If you see, a cough on an antihypertensive leads to switch classes rather than adding a cough suppressant. Which drug is this? A patient in shock receives an infusion. At a low dose, it increases renal blood flow. At moderate dose, it increases contractility and heart rate. At high dose, it produces marked vasoconstriction and raises systemic vascular resistance. Read the command. Which drug? One agent that changes its receptor profile as the dose rises is unusual, and that behavior identifies it. Dopamine is the catecholamine with a dose-dependent receptor profile. At low dose, it acts on D1 receptors, dilating renal and mesenteric vessels. At moderate dose, it recruits beta-1 receptors, increasing contractility and heart rate. At high dose, it recruits alpha-1 receptors, producing vasoconstriction and raising systemic vascular resistance. No other listed agent behaves this way. Noradrenaline is predominantly alpha with some beta-1 at all doses. Dobutamine is essentially pure beta-1, phenylephrine is pure alpha-1, and isoprenaline is pure beta. The correct answer is B. Matching the agent to the shock state is the clinical application and is examined directly. Noradrenaline is first line in septic shock, where the problem is vasodilation. Dobutamine suits cardiogenic shock, where the problem is contractility. And phenylephrine is useful when tachycardia must be avoided, since pure alpha stimulation causes reflex bradycardia rather than tachycardia. Low-dose dopamine for renal protection, once routine, has not shown clinical benefit. If you see a vasoactive drug with dose-dependent effects leads to think dopamine. Which pairing is correct? A 24-year-old man on an antipsychotic develops rigidity, fever of 40.1 degrees C, altered consciousness, autonomic instability, and a creatine kinase of 18,000 units per liter. A second patient on a serotonergic combination has agitation, hyperreflexia, clonus, diaphoresis, and dilated pupils. Read the command. Which pairing is correct? Two hypothermic syndromes share fever and altered consciousness, and the neuromuscular examination separates them. Neuroleptic malignant syndrome follows dopamine antagonism. It develops over days, and its signature is lead, pipe, rigidity, with massively elevated creatine kinase, fever, autonomic instability, and altered mentation. Reflexes are normal or reduced. Serotonin syndrome follows serotonergic excess. It develops over hours, and its signature is neuromuscular, hyperactivity, hyperflexia, clonus especially in the lower limbs, tremor, with agitation, diaphoresis, mydriasis, and diarrhea. Rigidity versus hyperreflexia is the discriminator, and choice A inverts it. The correct answer is C. Malignant hyperthermia completes the trio and is what choice? EMSA signs, it follows exposure to volatile anesthetics or succinyl within minutes, results from a RYR1 receptor mutation causing uncontrolled sarcoplasmic calcium release, and is treated with dantrol. All three cause hyperthermia and rhabdomyolysis, so the setting and the timescale, days, hours, or minutes, narrow the diagnosis before the examination even begins. If you see, drug-induced hyperthermia leads to let rigidity versus hyperreflexia decide, and check the timescale. Which class was given, and what is the mechanism? A 7-year-old boy is given an antibiotic for a respiratory infection and develops permanent gray-brown discoloration of his erupting permanent teeth. Read the command. Which class and the mechanism? Pediatric antibiotic contraindications are a short list with specific reasons. Tetracyclines, chelated valent cations, and that single chemical property explains nearly everything about them. Binding calcium in developing teeth and bone produces permanent discoloration and can inhibit bone growth, which is why they are avoided under age 8 and in pregnancy. The same chelation explains why absorption is markedly reduced by MILK, antacids, and iron. They must be taken apart from these. Choices B, C, D, and E attribute the effect to classes with different toxicities. The correct answer is A. Fluoroquinolones are the other class restricted in children and are the most tempting alternative here, so the distinction is worth holding. They damage cartilage rather than teeth, and in adults they carry the risks of tendinopathy and Achilles tendon rupture, especially with corticosteroids or in older patients, along with QT prolongation. Tetracyclines also cause marked pH photosensitivity, which appears in vignettes as a sunburn after minimal exposure. If you see an antibiotic contraindicated in children, leads to identify whether it affects teeth or cartilage. Which drug is responsible and what prevents this? A patient with tuberculosis on standard 4-drug therapy develops numbness and burning in both feet after 8 weeks. Vitamin B6 levels are low. Read the command, which drug and the prevention. Each tuberculosis drug has one signature toxicity, and one of them is routinely prevented. Isoniazid depletes pyridoxine, vitamin B6, by forming a complex that is excreted, and pyridoxine is required for the synthesis of myelin and neurotransmitters. The result is a dose-related peripheral neuropathy, which is why pyridoxine is given prophylactically with isoniazid, particularly in patients with diabetes, alcohol use, malnutrition, pregnancy, or HIV. Each of the other first-line drugs has a distinct signature. Rifampin causes orange body fluids and induces cytochrome P450. Ethambutol causes optic neuritis with red-green color blindness. Pyrazinamide causes hyperuricemia. The correct answer is D. Isoniazid carries two further associations worth attaching, since both appear as apparently unrelated findings in stems. It is a leading cause of drug-induced lupus alongside hydralazine and procainamide, identified by antihistamine antibodies, and its metabolism follows a genetic polymorphism. Slow axdylators reach higher levels and are more prone to both neuropathy and hepatitis. An example of pharmacogenetics the exam likes. If you see neuropathy on tuberculosis therapy, leads to think isoniazid and give pyridoxine. A 62-year-old woman on amiodarone for atrial fibrillation is reviewed. Which set of monitoring tests is most appropriate for this drug's characteristic toxicities? Read the command. Which monitoring is appropriate? The answer requires knowing which organs this particular drug damages. Amiodarone is remarkably effective and remarkably toxic, and its toxicities are organ-specific. It contains iodine and can cause either hypo or hyperthyroidism, so thyroid function must be monitored. It causes hepatotoxicity with transaminase elevation, and its most feared complication is pulmonary fibrosis, which may be irreversible, so baseline and periodic pulmonary function testing with diffusion capacity is standard. Choice E is untenable for a drug with this profile. The correct answer is B. Two pharmacological quirks explain why amiodarone appears so often in questions. It possesses properties of ALL4 antiarrhythmic classes, sodium channel blockade, beta blockade, potassium channel blockade, and calcium channel blockade, which is why it works when others fail. And its half-life is measured in weeks to months because of extensive tissue accumulation. So toxicity persists long after the drug is stopped, and drug interactions, including with warfarin and digoxin, are prolonged. If you see, amiodarone leads to monitored thyroid, liver, and lungs. Which statement about hypoglycemia risk is correct? Two diabetes drugs are compared. Drug 1 stimulates insulin release from beta cells independent of glucose level. Drug 2 reduces hepatic gluconeogenesis and improves insulin sensitivity without stimulating insulin secretion. Read the command, the statement about hypoglycemia risk. Whether a drug can cause hypoglycemia follows directly from whether it forces insulin release. Sulfonylureas close ATP-sensitive potassium channels on beta cells, depolarizing them and triggering insulin release regardless of the prevailing glucose. So if the patient does not eat, insulin is released anyway and hypoglycemia follows. They also cause weight gain. Metformin reduces hepatic gluconeogenesis and improves peripheral sensitivity without stimulating secretion, so used alone, it essentially does not cause hypoglycemia. It is weight neutral or mildly weight reducing. Choice D reverses both the risk and the toxicity. The correct answer is E. Metformin's own hazard is worth stating precisely because it drives real practice. LACT acidosis, rare but serious, occurs when the drug accumulates in renal impairment or when tissue hypoxia raises lactate production, which is why metformin is withheld around iodinated contrast and during acute illness. Classifying every diabetes drug by whether it forces insulin release answers most hypoglycemia questions in one step, and it also explains why insulin secretagogues require meal timing while sensitizers do not. If you see hypoglycemia risk in diabetes therapy leads to ask whether the drug forces insulin out. Which antidote is indicated? A 3-year-old is found with an empty bottle of her grandmother's tablets. She vomits, then develops abdominal pain with hematemesis. Hours later, she is hypotensive with an anion gap, metabolic acidosis, and a serum level confirms the ingestion. Read the command, which antidote? A pediatric ingestion with gastrointestinal hemorrhage followed by shock and acidosis points to one agent. Iron poisoning is among the commonest fatal pediatric ingestions, typically from prenatal vitamins. It is directly corrosive to gastrointestinal mucosa, producing vomiting, abdominal pain, and hematemesis in the first hours. Absorbed iron then acts as a mitochondrial poison, causing metabolic acidosis, shock, and hepatic necrosis, with a characteristic quiescent interval that falsely reassures. The chelating antidote is deferoxamine, which binds free iron and is excreted in urine, sometimes coloring it a vin rosé shade. The correct answer is C. Two practical details separate iron from other ingestions and are commonly tested. Activated charcoal does not absorb iron, so it is useless here, whereas whole bowel irrigation may help. And undissolved tablets are radiopaque on abdominal radiography. Matching chelator to methyl answers the rest of this family. Succimer or EDTA with dimercaprol for LE8, penicillamine for copper in Wilson disease, and dimercaprol for mercury and arsenic. If you see a toddler with hematemesis, then shock leads to think iron and give deferoxamine. Which enzyme inhibition explains the anemia? A 4-year-old living in a house built in 1935 has irritability, abdominal pain, and declining school performance. Hemoglobin is 9.1 grams per deciliter with basophilic stippling on the film and a microcytic anemia. Read the command, which enzyme inhibition? The environmental exposure names the toxin, and the toxin names the enzymes it blocks. Lead inhibits 2 enzymes in the heme synthesis pathway, furoxylate 80s, which inserts iron into protoporphyrin, and ALA dehydratase earlier in the pathway. Heme synthesis fails, producing a microcytic anemia with elevated protoporphyrin, and lead also inhibits ribosomal RNA degradation, leaving ribosomal remnants visible as basophilic stippling. The exposure is classically from lead paint in housing built before 1978, and children absorb it far more efficiently than adults. Choice E names the rate-limiting enzyme, which lead does not inhibit. The correct answer is D. The clinical presentation differs by age in a way the exam exploits. Children show cognitive and behavioral decline with abdominal pain, and radiographs may show dense LEAD lines at the metaphyses, while adults more often show a peripheral motor neuropathy with wrist drop or foot drop. Basophilic stippling has a short differential worth carrying: lead poisoning, thalassemia, sideroblastic anemia, and alcohol abuse. If you see basophilic stippling with microcytic anemia in a child leads to think lead. Which drug did he most likely take? And what was the antidote? A 68-year-old man in an ambulance is given an antidote for suspected poisoning. He has bradycardia, hypotension refractory to fluids and vasopressors, and hypoglycemia. The antidote raises intracellular cyclic AMP by a receptor-independent route. Read the command, the drug, and the antidote. One antidote works by bypassing a block receptor entirely, and that mechanism identifies both. Beta blocker overdose produces bradycardia and hypotension that resist catecholamines because the receptors those drugs act on are blocked. Hypoglycemia is the discriminating feature. Beta blockade impairs glycogenolysis and gluconeogenesis, and it also masks the adrenergic warning symptoms. Glucagon is the antidote because it stimulates adenyl cyclase through its OWN receptor, raising intracellular cyclic AMP and restoring inotropy and chronotropy, without needing the beta receptor. Calcium channel blocker overdose looks similar but classically causes hyperglycemia since insulin release is calcium dependent. The correct answer is A. The glucose direction is the cleanest discriminator between these two look-alike overdoses and is worth committing. Beta blockade lowers glucose, calcium channel blockade raises it because insulin secretion from the beta cell requires calcium influx. Note also the caution that arises in diabetes. A non-selective beta blocker both masks hypoglycemic warning symptoms and impairs recovery, which is why it is used carefully in insulin-treated patients. If you see, bradycardia with hypotension leads to let the glucose tell you which channel is blocked. Which pairing is correct? Two antimicrobials inhibit bacterial protein synthesis. Drug 1 binds the 30S subunit and requires oxygen-dependent uptake, so it is ineffective against anaerobes and is bactericidal. Drug 2 binds the 50S subunit, is bacteriostatic, and inhibits cytochrome P450. Rate the command, which pairing is correct. Ribosomal subunit, bactericidal status, and oxygen dependence together identify each class. Ammonioglycosides bind the 30S subunit and are bactericidal, unusual among protein synthesis inhibitors. Their uptake into bacteria requires an oxygen-dependent transport system, which is why they are ineffective against anaerobes, and why they are often paired with a cell wall agent that improves penetration. Macrolides bind the 50S subunit, are bacteriostatic, and are notable P450I inhibitors, which is how they raise warfarin and statin levels. Choice A reverses the two. The correct answer is B. The mnemonic for the subunits is worth carrying. By AT30, CCEL at 50, where aminoglycosides and tetracyclines act at 30S, while chloramphenicol, clindamycin, erythromycin, and linezolid act at 50S. Each class then carries its own signature toxicity. Aminoglycosides are nephrotoxic and otoxic. Macrolides prolong the QT interval. Clindamycin is the classic precipitant of Clostridioides difficile colitis, and chloramphenicol causes aplastic anemia and gray baby syndrome. If you see a protein synthesis inhibitor leads to place the subunit, then recall its toxicity. Which class caused this and which patients are at highest risk? A patient with severe community-acquired pneumonia is given a beta-lactam plus a second agent that inhibits bacterial DNA gyrase. Days later, he develops Achilles tendon pain and cannot dorsiflex the ankle. Read the command, the class, and the highest risk patients. The enzyme name in the stem identifies the class before the toxicity is even considered. Fluoroquinolones inhibit DNA. Gyrase, which is topoisomerase II, and topoisomerase IV, enzymes that manage bacterial DNA supercoiling. Their most distinctive adverse effect is tendinopathy progressing to rupture, classically of the Achilles tendon, and the risk is concentrated in older patients, those on corticosteroids, and transplant recipients. They also damage growing cartilage, which is why they are avoided in children and pregnancy, and they prolong the QT interval. The correct answer is E. Their absorption shares a pitfall with tetracyclines and is examined the same way. Divalent and trivalent, cations in antacids, calcium or iron supplements. Chelate, fluoroquinolones, and markedly reduce absorption, so dosing must be separated. Choice A. Names a class whose toxicity is renal and cochlear rather than musculoskeletal. And choice D names the class that affects teeth and bone growth rather than tendons. If you see tendon rupture on an antibiotic leads to think fluoroquinol. Which mechanism explains this complication? A 58-year-old man on simvastatin is started on clarithromycin. 10 days later, he has severe diffuse muscle pain and weakness. Creatine kinase is 34,000 units per liter, and urine dipstick is positive for blood with no red cells. Read the command, the mechanism. This is a drug interaction question wearing the clothes of a muscle disease. Simvastatin is metabolized by CYP3A4. Clarithromycin is a potent CYP3A4 inhibitor, so statin levels rise several fold, and statin myotoxicity is concentration dependent, progressing from myalgia to myositis to frank arrhythmomyolysis, with the creatine kinase elevation seen here. The positive dipstick for blood with no red cells reflects myoglobin, exactly as in the rhabdomyolysis discussed in the renal session, and it threatens pigment-induced acute kidney injury. The correct answer is B. The list of interacting agents is worth holding because the interaction is common and preventable. Azo antifungals, protease inhibitors, cyclosporin, amiodarone, verapamil, and grapefruit juice all raise statin exposure through the same route, and combining a statin with a fibrate, ET, gemfibrozil in particular, independently increases myopathy risk. Pravastatin and rosuvastatin, which are less dependent on CYP3A4, are often chosen when such combinations are unavoidable. If you see rhabdomyolysis on a statin leads to look for the drug that inhibited its metabolism. Which two drugs are these? A woman with epilepsy is planning pregnancy. Her current drug is associated with a 1 to 2% risk of neural tube defects, and she also takes the second medication that is a known cause of Epstein anomaly. Read the command, which two drugs? Teratogens are matched to specific malformations, and two of them are named directly in the stem. Valproate carries the highest teratogenic risk among common antiepileptics, causing neural tube defects in 1 to 2% of exposed pregnancies along with cognitive impairment. It is avoided in women of childbearing potential where alternatives exist, and high-dose folate is given when it cannot be. Lithium is the classic cause of EBST anomaly, in which the tricuspid valve is displaced apically into the right ventricle. Choice A pairs lithium correctly with a drug that is comparatively safe in pregnancy. The correct answer is D. This is one of the highest yield lists in pharmacology because the associations are specific and repeatedly tested. Two further points recur. Heparin does not cross the placenta and is therefore the anticoagulant of choice in pregnancy, whereas warfarin does. And the first trimester is the period of organogenesis and greatest structural risk, while later exposure more often affects growth and function, which is why the timing of exposure appears in the stem. If you see a malformation in the stem leads to look for the drug that pairs with it specifically. Which additional metabolic effect is characteristic of this drug? A patient with hypertension is prescribed hydrochlorothiazide. At follow-up, glucose has risen, uric acid has risen, potassium has fallen, and sodium has fallen. Read the command. Which additional effect is characteristic? Thiazides have a recognizable metabolic fingerprint, and one element of it is missing from the stem. The thiazide metabolic profile is summarized as hyper-GLUC, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia, alongside hypokalemia, hyponatremia, and a metabolic alkalosis. Hyperlipidemia is the element missing from the stem. Note that calcium moves up, not down. Thiazides enhance distal calcium reabsorption, which is why choice A is wrong and why these drugs are useful in calcium stone prevention. The alkalosis rather than acidosis excludes choice D. The correct answer is C. The hypouricemia has direct clinical consequence and is a favorite second-order question. Thiazides compete with urate for tubular secretion, raising serum urate and potentially precipitating GOUT, so an alternative is preferred in a patient with gout. Contrasting the two diuretic classes across the same axis is the efficient way to hold this. Thiazides retain calcium and cause hypernatremia readily, while loops lose calcium and add ototoxicity. If you see metabolic derangements on a diuretic leads to check which direction the calcium moved. Which mechanism explains this crisis? A 26-year-old woman with depression on phenelzine eats aged cheese and cured meats at a party. 2 hours later, she has severe headache, blood pressure of 220 over 125 millimeters of mercury, and palpitations. Read the command, the mechanism of the crisis. A dietary interaction with a specific enzyme inhibitor produces a hypertensive emergency. Tyramine is a sympathomimetic amine abundant in aged cheeses, cured meats, fermented foods, and some wines. Normally, it is degraded by monoamine oxidase in the gut wall and liver before reaching the circulation. When MAO is inhibited, tyramine is absorbed intact, enters sympathetic nerve terminals, and disperses stored noradrenaline into the synapse, producing a massive sympathetic surge with severe headache, hypertensive crisis, and risk of intracranial hemorrhage. Choice B misplaces the action at the receptor rather than at the vesicle. The correct answer is A. The other prohibition attached to this class is equally examinable and rests on a different mechanism, combining an MAO inhibitor with an SSRI, meperidine, tramadol, or dextromethorphan risks serotonin syndrome, so a washout of about 2 weeks is required when switching, 5 weeks after fluoxetine because of its long-lived active metabolite. The hypertensive crisis itself is treated with pentylamine, a reversible alpha antagonist. If you see hypertensive crisis after cheese leads to think tyramine and a monoamine oxidase inhibitor. What is the purpose of the second agent? A 71-year-old man with Parkinson's disease is treated with levodopa combined with carbidopa. Read the command. The purpose of the second agent. Combination therapy in Parkinson's disease is a lesson in where a drug is allowed to act. Dopamine itself cannot cross the blood-brain barrier, so levodopa, its precursor, is given instead. The problem is that levodopa is decarboxylated to dopamine in peripheral tissues before reaching the brain, producing nausea, orthostatic hypotension, and arrhythmia while wasting most of the dose. Carbidopa is a peripheral dopa, decarboxylase inhibitor, that does not cross the blood-brain barrier, so it blocks that peripheral conversion only, increasing central delivery and reducing peripheral side effects. Choice A inverts the essential property. The correct answer is E. Not crossing the barrier is precisely what makes carbidopa useful, which is the conceptual inversion. The question tests a limitation deployed as a feature. The other adjuncts named in the wrong answers are all real drugs with distinct roles. Entacapone inhibits COMT to prolong levodopa's action. Acetaminophen inhibits MAO, B to slow central dopamine breakdown, and dopamine agonists act directly at the receptor and are often preferred in younger patients to delay levodopa-related dyskinesias. If you see a combination drug in Parkinson's disease leads to ask which side of the barrier each agent works on. What is the most appropriate reversal strategy? A patient with a prosthetic heart valve requires urgent surgery. His INR is 4.2 and surgery cannot be delayed. Read the command. The reversal strategy. Urgency determines which reversal agent is appropriate, and the anticoagulant determines which one works at all. Warfarin reversal is chosen by urgency. For a raised INR, without bleeding and without urgency, withholding doses with or without oral vitamin K suffices, since vitamin K takes 12 to 24 hours to restore factor synthesis. When reversal must be IM immediate, active major bleeding or emergency surgery, the deficient factors must be replaced. Prothrombin complex concentrate contains factors 2, VIM, X, and X, works within minutes, and is given with intravenous vitamin K to sustain the correction after the concentrate is cleared. The correct answer is D. Choice C is the classic wrong drug trap. Protamine is the antidote for heparin, binding it directly, and it has no effect on warfarin. Fresh frozen plasma in choice B does contain the factors but requires large volumes and considerable time to infuse, so it is a fallback rather than the preferred option. The direct oral anticoagulants have their own agents. Idarucizumab for dabigatran and andexanet alpha for the factor EKXI inhibitors. If you see anticoagulant reversal leads to match the antidote to the drug, then to the urgency. Which pairing is correct? 2 patients receive different diuretics. Patient 1 develops gynecomastia and hyperkalemia. Patient 2, on a different potassium-sparing agent, develops hyperkalemia without any endocrine effect. Read the command. Which pairing is correct? Two potassium-sparing diuretics act at the same site by different means, and one has an endocrine footprint. Both drugs act in the collecting duct and both spare potassium, but by different mechanisms. Spironolactone is a competitive aldosterone rectorinase, and because that receptor is a steroid receptor, the drug also has anti-androgenic effects, producing gynaecologic effects, producing gynecomastia, decreased libido, and menstrual irregularity. Amiloride and triamterene block the epithelial SO-diam channel directly, sparing potassium without touching any hormone receptor, so they cause no endocrine effects. Choice B reverses them. Correct answer is A. Eplerenone exists precisely to solve this problem and is the reason the distinction matters clinically. It is a selective aldosterone antagonist without significant anti-androgenic activity, so it is substituted when gynecomastia limits spironolactone. Spironolactone's anti-androgenic effect is also used deliberately in hirsutism from polycystic ovary syndrome and in acne, turning an adverse effect into an indication. If you see gynecomastia on a diuretic leads to think spironolactone and consider eplerenone. Which condition is this, and what is the mechanism? A 54-year-old man on a first-generation antipsychotic for 6 years develops involuntary lip-smacking, tongue protrusion, and chorioethatoid movements of the hands. Increasing the antipsychotic dose temporarily suppresses the movements. Read the command, the condition, and the mechanism. Antipsychotic movement disorders are separated by how long after starting they appear. The extrapyramidal effects follow a timeline. ACUD dystonia appears within hours to days as sustained muscle spasm treated with anticholinergics. Akathisia appears within days to weeks as motor restlessness. Parkinsonism appears over weeks to months. Tardive dyskinesia appears after months to years as involuntary orofacial and chorioethatoid movements, and it is thought to result from postsynaptic dopamine receptor, U, pregulation and supersensitivity after prolonged blockade, which is why raising the dose temporarily masks it while worsening the underlying process. The correct answer is E. The paradox that raising the dose suppresses the movements is diagnostically useful and therapeutically misleading, which is what makes it worth including. More blockade temporarily masks the supersensitive receptors while driving further upregulation. Management is to reduce or switch the antipsychotic. L-alzapine carries the lowest risk, and to consider a VMAT2 inhibitor such as valbenazine. Unlike the earlier extrapyramidal effects, tardive dyskinesia is often IRR reversible, which is why early recognition matters. If you see involuntary orofacial movements after years of antipsychotic use, leads to think tardive dyskinesia. Which monitoring is specifically required for this drug? A patient with schizophrenia refractory to 2 prior antipsychotics is started on clozapine. Read the command. Which monitoring is specifically required? One antipsychotic carries a mandatory blood count schedule, and the reason is a specific fatal complication. Clozapine is the most effective antipsychotic for treatment-resistant schizophrenia and is uniquely associated with reduced suicidality, but it carries a risk of agranulocytosis in roughly 1% of patients, which can be fatal through overwhelming infection. Mandatory monitoring of the absolute neutrophil count, frequent at first and less often thereafter, is therefore a condition of prescribing. It also causes myocarditis, seizures at higher doses, marked weight gain and metabolic syndrome, and severe sialorrhea. The correct answer is C. Placing clozapine within its class explains why it is reserved rather than first line. The atypical antipsychotics as a group cause metabolic syndrome with weight gain, dyslipidemia, and hypoglycemia, requiring glucose and lipid monitoring, while carrying less extrapyramidal risk than the first-generation drugs. Clozapine sits at the extreme of both, the lowest movement disorder risk and the highest hematological and metabolic burden. If you see, clozapine leads to the answer involves the neutrophil count. What is this drug? A drug binds the same receptor as a full agonist but produces only 40% of the maximal response even at receptor saturation. When given together with the full agonist, the overall response falls. Read the command. What this drug is. Producing a submaximal effect while reducing a full agonist effect describes one category exactly. A partial agonist binds the receptor and activates it, but with lower intrinsic activity, so its maximal effect is submaximal no matter how much is given, because it occupies the receptor. It also displaces a full agonist and pulls the combined response down toward its own ceiling, behaving as a functional antagonist in the presence of the full agonist. That dual behavior is the signature. A competitive antagonist, by contrast, has zero intrinsic activity and produces no effect alone, which excludes choice A. The correct answer is B. The clinical examples make the concept concrete and are themselves examinable. Buprenorphine is a partial mu-opioid agonist used in opioid dependence precisely because its ceiling limits respiratory depression, while its receptor occupancy blocks full agonists. Varenicline does the same at nicotinic receptors for smoking cessation. ARIP. Pyrazole is a partial dopamine agonist. Choice D names a distinct category. An inverse agonist produces the opposite effect by stabilizing the inactive receptor state. If you see a drug with a ceiling that also blocks a full agonist, leads to think partial agonist. Which toxidromes are these? A patient is brought in agitated with dry, flushed skin, dilated pupils, urinary retention, absent bowel sounds, and a temperature of 39.0 degrees C. A second patient has diaphoresis, meiosis, salivation, bronchorrhea, and hyperactive bowel sounds. Read the command. Which toxidromes? Two syndromes are exact mirror images, and the skin alone can separate them. The anticholinergic toxidrome is described by a run of similes: hot as a hair from hypothermia, dry as a bone from absent secretions, red as a beet from cutaneous vasodilation, blind as a bat from mydriasis and loss of accommodation, and mad as a hatter from delirium, with urinary retention and absent bowel sounds. The cholinergic toxidrome is its mirror in every respect: diaphoresis, meiosis, salivation, bronchorrhea, hyperactive bowel sounds. Choice B reverses them. The correct answer is E. The DRY versus WET distinction is the single most reliable bedside discriminator and separates the anticholinergic patient from the sympathomimetic one too, which is worth adding. Cocaine and amphetamine toxicity also produce agitation, hyperthermia, and mydriasis, but with profuse diaphoresis and normal or hyperactive bowel sounds. Because sympathetic stimulation drives sweating, while antimuscarinic action abolishes it. Feeling the skin answers what the vital signs cannot. If you see agitation with hyperthermia and mydriasis leads to feel the skin before naming the toxidrome. Why is the pulse oximetry reading misleading, and what is the treatment? A patient in a house fire has soot in the nares, a normal PO2, and a pulse oximetry reading of 98%. He is confused with a headache. Carboxyhemoglobin is 32%. Read the command. Why oximetry misleads and what to give. The instrument's limitation is the diagnostic point. Standard pulse oximetry uses two wavelengths and cannot distinguish carboxyhemoglobin from oxyhemoglobin, so it reads falsely. Normal in carbon monoxide poisoning. The reading reflects occupied binding sites, not useful oxygen. The PO2 is also normal because dissolved oxygen is unaffected. What has collapsed is oxygen content and delivery, since carbon monoxide binds hemoglobin with about 240 times the affinity of oxygen and left shifts the dissociation curve. Treatment is 100% oxygen, which accelerates elimination, with hyperbaric therapy in severe cases. The correct answer is C. Choice. And names the other hemoglobin poisoning, and the contrast completes the pair. Methemoglobin. Pyonemia drives the oximetry reading toward a fixed value near 85% and produces chocolate. Brown blood, and it is treated with methylene blue. Both share normal power T with impaired carriage, and both require CO oximetry, which measures each hemoglobin species separately, rather than standard pulse oximetry. If you see, a normal saturation after a fire leads to distrust the oximeter and measure carboxyhemoglobin. Which mechanism explains this? A patient with a new diagnosis of gout is started on allopurinol. He also takes azathioprine for inflammatory bowel disease. Within 2 weeks, he develops profound pancytopenia. Read the command mechanism. One enzyme sits in both drug pathways, and inhibiting it has an outsized effect. Allopurinol inhibits xanthine oxidase to reduce uric acid production. Azathioprine is a prodrug converted to 6-mercaptopurine, and one of the principal routes of 6-mercaptopurine ion activation is xanthine oxidase. Blocking that enzyme therefore causes 6-mercaptopurine to accumulate to toxic levels, producing severe myelosuppression with pancytopenia. The combination requires either avoidance or a substantial dose reduction, typically to about a quarter, with close blood count monitoring. The correct answer is B. 2 further points about allopurinol recur in questions and are worth attaching. It should not be started during an ACU gout attack because shifting urate levels can prolong the flare. Treatment begins with an NSAID, colchicine, or steroid, and urate-lowering therapy follows once the attack settles. And severe cutaneous reactions, including Stevens-Johnson syndrome, are associated with the HLA B8201 allele, which is screened for in some populations. If you see, pancytopenia after adding allopurinol leads to leukothioporine. What is the appropriate response? A 66-year-old woman with atrial fibrillation and a mechanical mitral valve asks whether she can switch from warfarin to a direct oral anticoagulant for convenience. Read the command. The appropriate response. Direct oral anticoagulants have largely displaced warfarin, with specific exceptions that are examined precisely because they are exceptions. Direct oral anticoagulants are preferred over warfarin for most indications: non-valvular atrial fibrillation, venous thromboembolism, because they need no routine monitoring and have fewer interactions. But in patients with mechanical heart valves, warfarin remains required. Trials of dabigatran in this population showed more thromboembolic and bleeding events, and the trial was stopped early. Choice B names precisely the drug that was tested and failed, making it the most instructive wrong answer. The correct answer is D. The term non-valvular atrial fibrillation exists precisely to mark this boundary, and it is worth reading carefully in a STEM. It excludes mechanical valves and moderate to severe mitral stenosis, the 2 settings where warfarin remains standard. The other practical limitation is renal. Direct oral anticoagulants are cleared renally to varying degrees, so dosing must be adjusted, and some are contraindicated in advanced kidney disease. If you see, a mechanical valve and an anticoagulant question leads to the answer is warfarin. Which pairing is correct, and what do both classes achieve? A patient with severe asthma is given a drug that blocks leukotriene receptors. A second patient receives a drug that inhibits 5-lipoxygenase. Read the command, the pairing, and what both achieve. 2 drugs interrupt the same pathway at different points. Arachidonic acid is metabolized down 2 branches. The lipoxygenase branch produces leukotrienes, which cause bronchoconstriction, mucus secretion, and eosinophil recruitment. Montelukast blocks the leukotriene receptor. Xylutin inhibits 5-lipoxygenase and therefore blocks leukotriene synthesis. Both reduce leukotriene-mediated bronchoconstriction at different points in the synthesis. Both reduce leukotriene-mediated bronchoconstriction at different points in the same pathway recruitment. Choice E names the other branch entirely. Cyclooxygenase leads to prostaglandins and thromboxane. The correct answer is A. The pathway explains one syndrome particularly well, and is why these drugs have a specific niche in aspirin exacerbated respiratory disease, asthma with nasal polyps, and aspirin sensitivity. Blocking cyclooxygenase shunts arachidonic acid down the lipoxygenase branch, overproducing leukotrienes and precipitating bronchospasm. Leukotriene-directed therapy is therefore particularly effective in that group. If you see, montelukast or serotonin leads to trace arachidonic acid down the lipoxygenase branch. Which mechanism explains this interaction? A man with erectile dysfunction takes sildenafil and later that evening is given sublingual nitroglycerin for chest pain. He becomes profoundly hypotensive. Read the command, the mechanism. Two drugs converge on the same second messenger from different directions. Nitrates donate nitric oxide, which activates guanylyl cyclase and intrases cyclic GMP, relaxing vascular smooth muscle. Sildenafil inhibits phosphodiesterase type 5, the enzyme that degrades cyclic GMP, so it prevents breakdown. Given together, one drug increases production while the other blocks removal, and cyclic GMP accumulates dramatically. The result is profound, refractory vasodilation and hypotension, which is why the combination is absolutely contraindicated and a nitrate-free interval of 24 to 48 hours is required. The correct answer is C. The retinal effect is a neat illustration of selectivity being imperfect and appears in questions as an odd visual complaint. PDE6 in retinal photoreceptors is structurally similar to PDE5, so partial inhibition produces a transient BLU, tinted visual disturbance. Note also the second indication for this class. Sildenafil and tadalafil are used in pulmonary arterial hypertension, exploiting the same pulmonary vasodilation. If you see a nitrate with a PDE5 inhibitor leads to expect additive vasodilation and refuse the combination. Which process is occurring? A patient with rheumatoid arthritis on long-term prednisone is admitted with pneumonia and becomes hypotensive despite fluids and vasopressors. Serum cortisol is inappropriately low for the degree of stress. Read the command. Which process? Long-term exogenous steroid changes how the adrenal responds to a crisis. Chronic exogenous glucocorticoid suppresses hypothalamic CRH and pituitary ACTH by negative feedback, and the adrenal cortex atrophies. Under normal conditions, the exogenous dose substitutes adequately, but under major stress TRS, infection, surgery, trauma, the demand rises several-fold and the suppressed axis cannot respond. The result is adrenal crisis, hypotension refractory to fluids and vasopressors with an inappropriately low cortisol. Treatment is immediate stress dose hydrocortisone, and choice C will leave that untreated. The correct answer is B. Distinguishing this from primary adrenal insufficiency is straightforward once the mechanism is clear, and choice. Supplies the contrast. In primary disease, the adrenal itself is destroyed, so ACTH is Hitch, producing Hitch. Producing hyperpigmentation. A mineralocorticoid is lost as well, producing hyperkalemia and hyponatremia. Secondary suppression spares the mineralocorticoid axis, which is regulated by renin rather than ACTH, so potassium is typically normal. If you see refractory hypotension in a patient on chronic steroids leads to give stress dose hydrocortisone. Which classes are these? Two antiarrhythmics are compared. Drug 1 blocks potassium channels, prolongs repolarization, and lengthens the QT interval. Drug 2 blocks sodium channels with strong use, dependence, and markedly slows conduction without prolonging repolarization. Read the command. Which classes? A Vaughan Williams classification maps channel to effect to electrocardiographic change. Class 3 agents block potassium channels, prolonging repolarization, and therefore the QT interval, sotalol, amiodarone, dofetilide, ibutylide, with the attendant risk of torsades depoints. Class I agents block sodium channels. Among them, Class IC, flecainide and propafenone, have the strongest binding with marked use. Dependence, widening the QRS and slowing conduction with little effect on repolarization. Class IA prolongs both, and Class IB shortens repolarization. Choice B reverses the two. The correct answer is A. The prohibition attached to Class IC is one of the most consequential in cardiology and stems from a landmark trial. Flecainide and propafenone increase in mortality when used to suppress ectopy after myocardial infarction, so they are avoided in structural heart disease and reserved for patients with normal hearts. Toxidromes from Class 3 agents is treated with intravenous magnesium regardless of the serum magnesium level. If you see an antiarrhythmic leads to name the channel first, then the electrocardiographic consequence. Which phenomenon is this? A patient with chronic pain on morphine develops progressively less analgesia at the same dose, requiring escalation. He has no evidence of disease progression and no drug-seeking behavior outside prescribed use. Read the command. Which phenomenon? 4 terms in opioid therapy are routinely conflated, and each means something specific. Tolerance is a pharmacological phenomenon. With repeated exposure, more drug is required to achieve the same effect through receptor downregulation and desensitization. It is expected, is not a disorder, and carries no moral weight. PHY cycle dependence is a separate expected phenomenon, a withdrawal syndrome on abrupt cessation. ADD addiction is a behavioral disorder of compulsive use despite harm, and it is explicitly absent here. Choice B names a real concept, apparent drug seeking that resolves once pain is adequately treated, but it does not describe diminishing effect. The correct answer is E. The clinically important asymmetry is that tolerance does not develop uniformly. It develops readily to analgesia, euphoria, and respiratory depression, but essentially not to constipation or amiosis. This is why a laxative regimen is started alongside chronic opioids rather than waiting for symptoms, and why pinpoint pupils remain a reliable sign of opioid effect even in a highly tolerant patient. If you see an opioid term in a stem leads to separate the pharmacology from the behavior. Which enzyme deficiency is present and what does it impair? A 30-year-old man of Mediterranean descent is given primaquine for malaria and develops acute anemia with dark urine. Blood film shows bite cells and Heinz bodies. Read the command, the enzyme, and what it impairs. An oxidative drug precipitating hemolysis points to one pathway. Glucose 6 phosphate dehydrogenase is the rate-limiting enzyme of the pentose phosphate pathway, whose function in the red cell is generating NADPH. NADPH keeps glutathione reduced, and reduced glutathione neutralizes oxidative stress. Without it, oxidized hemoglobin precipitates as Heinz bodies, which splenic macrophages pluck out, leaving by CEH. Triggers include primaquine, dapsone, sulfonamides, nitrofurantoin, flavabines, and, importantly, eye infection itself. The correct answer is D. The testing pitfall is a favorite examination point and follows from the mechanism. During an acute episode, the most deficient cells have already lysed, so the enzyme assay performed on surviving young cells can be falsely normal. Testing is deferred for several weeks. The same NADPH is used by the phagocyte respiratory burst, which is why severe deficiency can mildly impair bacterial killing, connecting this enzyme to the chronic granulomatous disease seen in the immunology session. If you see hemolysis after an oxidant drug with bite cells leads to think G6PD and test later. Which is the most appropriate treatment for the acute attack? A patient with an acute gout flare and a creatinine of 2.4 milligrams per deciliter cannot take nonsteroidal anti-inflammatory drugs. He has no infection. Read the command, the treatment for the acute attack. Gout therapy divides into treating the flare and lowering urate long-term, and mixing them worsens the patient. Acute gout is an inflammatory problem treated with an anti-inflammatory, NSAIDs, colchicine, or corticosteroids. With renal impairment excluding NSAIDs and limiting colchicine, a corticosteroid intra-articular for a single joint, oral for polyarticular disease is the appropriate choice, provided septic arthritis has been excluded. Urate, Lowering therapy is a separate matter. Allopurinol, febuxostat, and probenecid are for prevention and should not be initiated during a flare, since shifting urate levels can prolong it. The correct answer is A. One nuance completes the rule and is frequently tested. If a patient is already established on allopurinol when a flare occurs, it should be continued rather than stopped. It is the change in urate level, not its absolute value, that provokes attacks. When urate-lowering therapy is eventually started, prophylactic colchicine or an NSAID is given alongside for several months to cover the mobilization period. Aspirin at low dose raises urate and is best avoided. If you see an acute gout flare leads to give an anti-inflammatory and postpone the urate-lowering drug. Which pharmacological principle best explains his presentation? A 70-year-old man takes 12 prescribed medications. He presents with a fall and confusion. Review identifies diphenhydramine for sleep, oxybutynin for urinary urgency, and amitriptyline for neuropathic pain. Read the command. Which principle explains the presentation? 3 drugs from different classes share one property, and the effect is additive. Diphenhydramine, oxybutynin, and amitriptyline belong to different therapeutic classes, but all have substantial antimuscarinic activity. Their effects: some, producing a cumulative anticholinergic burden, confusion, falls, urinary retention, constipation, dry mouth, and blurred vision. All the patients are disproportionately affected because central cholinergic reserve declines with age and the blood-brain barrier becomes more permeable, so the same burden produces more delirium. Choice: E names the opposite direction entirely. The correct answer is B. The management principle is the point of the question and is examined as much as the pharmacology. The correct response is to deprescribe, to remove the offending agents rather than to add a new drug for each symptom, which produces a prescribing cascade. Formal tools such as the Beers criteria list these agents as potentially inappropriate in older adults for exactly this reason, and each drug here has a safer alternative. If you see confusion and falls in a polypharmacy patient leads to add up the anticholinergic burden. Which statement about removing this drug is correct? A drug has a volume of distribution of 500 L and is 98% protein bound. A patient has taken a large overdose. Read the command. Which statement about removal is correct? 2. Pharmacokinetic parameters. Determine whether dialysis can help. Dialysis removes drug from plasma, so it can only work when a meaningful fraction of the drug is in the plasma and free. A large volume of distribution means the drug has left the circulation and is sequestered in tissue. 500 liters far exceeds total body water, so almost none remains in plasma to be removed. High protein binding compounds the problem because bound drug does not cross the dialysis membrane. Both parameters here point the same way, so dialysis is largely ineffective. The correct answer is E. The dialyzable list is worth committing because these questions ask it directly. Methanol, ethylene glycol, salicylate, lithium, theophylline, and valproate share small volumes of distribution and low protein binding. Digoxin and tricyclic antidepressants are the classic non-dialysable poisons, which is exactly why each has its own specific antidote, digoxin antibody and sodium bicarbonate respectively, rather than an extracorporeal solution. If you see a dialysis question in toxicology leads to check the volume of distribution and protein binding. Which dosing parameter determines the loading dose, and which determines maintenance? A patient starting a new drug requires a target plasma concentration achieved immediately. The drug has a large volume of distribution and a long half-life. Read the command. Which parameter determines each dose? 2 different questions about a drug require 2 different constants. A loading dose fills the body's apparent space to reach the target concentration at once, so it is the target concentration multiplied by the volume of distribution, and it does not depend on how fast the drug is eliminated. A maintenance dose replaces what is being removed per unit time, so it is the target concentration multiplied by clearance. The consequences are practical. In renal or hepatic impairment, clearance falls, so the maintenance dose must be reduced while the loading dose is unchanged. Choice A inverts both. The correct answer is D. The reason the loading dose exists at all follows from the same arithmetic. Steady state is reached after 4 to 5 HAF lives, no matter what maintenance dose is chosen. So for a long half-life drug that could take days, unacceptable when the effect is needed now. Giving the volume-based loading dose jumps directly to target, after which clearance-based maintenance holds it there. If you see loading versus maintenance dosing leads to volume fills the space, clearance sustains it. Which drug classes are most commonly implicated, and what is the immediate step? A patient develops a fever and a widespread painful rash with mucosal involvement of the eyes and mouth, an epidermal detachment over 25% of the body's surface, 2 weeks after starting a new drug. Read the command, the implicated classes, and the immediate step. A severe cutaneous drug reaction has a short list of culprits and one non-negotiable action. Mucosal involvement with epidermal detachment defines the Stevens-Johnson and toxic epidermal. Necrolysis spectrum, separated by the extent of detachment, under 10% is Stevens-Johnson, over 30% is toxic epidermal necrolysis, and between the two is overlap, as here. The classic culprits are sulfonamides anticonvulsants such as carbamazepine, lamotrigine, and phenytoin, allopurinol, NSAIDs, and some antibiotics. The immediate step is to stop the offending drug with supportive care in a burns unit, since mortality rises with detachment area. The correct answer is C. 2 further points recur. First, pharmacogenomic screening exists for this. HLA-BH15-02 predicts carbamazepine-induced Stevens-Johnson syndrome in Han Chinese and some other Asian populations, and HLA-BH58-01 predicts allopurinol reactions. Second, the syndrome must be distinguished from DRES, drug reaction with eosinophilia and systemic symptoms, which appears later at 2 to 8 weeks, with facial edema, eosinophilia, and organ involvement rather than epidermal detachment. If you see a rash with mucosal involvement after a new drug leads to stop the drug before anything else. 50 questions done, 5 discriminators worth carrying out of this session. Every one of those separated 2 drugs or 2 poisonings that presented alike and diverged on one parameter. Find the parameter and the question answers itself. Next in the series, hematology, oncology, and gastrointestinal. StepLogic. Learn how to think, not memorize.